All right, we're going to go ahead and get started with the last session of the afternoon on controversies in AKI. I'm Mitch Rosner from the University of Virginia. I'm joined with my co-moderator, Stu Goldstein from the University of Cincinnati. We have 5 terrific speakers who I think will really set the stage for an interesting discussion. We're going to ask the speakers to keep to their time limit, so we have time at the end of the session for plenty of discussion. So our first speaker discussing renal functional reserve is Professor Claudio Ronco from Vicenza, Italy. Claudio, probably well known to just about everybody in this room, certainly a luminary in the field of acute kidney injury, and we'll discuss functional reserve. So Claudio, welcome.
Good afternoon once more. Thank you very much for the kind invitation. We have been discussing for many years the process of filtration and tubular uptake, and I have this fantastic, nice slides from Bruce Molitoris clearly showing how you can get in vivo information about glomerular filtration. Now, however, before describing what is going wrong about glomerular filtration, one should define what is the normal renal function. And sometimes we lose the perspective just measuring glomerular filtration rate by losing the concentration on the focus on other things, including concentration dilution capacity, endothelial reflection coefficient, endocrine secretion capacity, and so on and so on. Now, glomerular filtration rate is accepted as the best overall index for kidney function, and we know that normal GFR may vary according to age, sex, and body size. While it decreases generally when there is a clinical kidney failure, when it is persistently reduced, then we speak about chronic kidney disease, while an abrupt reduction usually indicates AKI. Certainly below 60 in general, our complication and risk for major adverse cardiac and renal events increase dramatically. We know that there is a progressive decrease with the age in the basal glomerular filtration rate, both in men and women. But the problem in general, when we ask ourselves what's GFR, the question is, which GFR are we talking about? And sometimes we need to have lost more than 50% of the nephrons before we can see a decrease in GFR, which result in an increase in serum creatinine. So, given the fact that there are significant variations of baseline GFR during the day, depending on diet, fasting, and activity, and so on, which one is the GFR that we are measuring in a patient? What GFR are we referring to? Now, we know that there are several regulatory mechanisms that may help these physiological changes in GFR, and some cases are inducing pathological variations, including variations in pressure-flow relationship, what we call autoregulation, capillary wall permeability, filtration fraction, glomerular tubular feedback, and so on, and so on. All the mechanisms that are inducing possible adjustment if normal kidney or pathological variation in the kidney. So the regulatory mechanism of glomerular filtration rates are basically depending on the adjustment of the afferent and efferent arterial vasoconstriction and vasodilatation. And we know very well that while in the normal kidney, perfusion pressure definitely affect the perfusion of the kidney, but only in part due to the phenomenon called autoregulation. When the kidney has lost autoregulation, then changes, even marginal in mean arterial pressure, may actually affect renal blood flow and glomerular filtration rate. And also we know that there are conditions such as hypertension, atherosclerosis that may decrease filtration fraction and decrease glomerular filtration rate, or conditions like diabetes, nephrotic syndrome, heart failure, in which you have an efferent vasoconstriction and increase in filtration fraction to keep the glomerular filtration going. Assuming that when, for example, you deliver ACE inhibitors or other drugs that may affect the tone of the efferent arteriolar component, you may actually have an efferent vasodilatation which reduces filtration fraction and apparently decrease glomerular filtration rate and renal function. So we have several factors affecting GFR, including actually creatinine generation if we use creatinine as an endogenous filtration markers. And we have to consider and we have to consider that these drugs may actually implement the mechanism of regulation between afferent and efferent arteriolar tone so that different drugs and hormones may have an effect on what we call baseline GFR. Now, we also know that there is a biodiversity and different people may have different number of nephrons, and congenital conditions may actually affect what we call renal frailty or renal susceptibility to different insults. And while the phenotype may be affected by prenatal perturbation and reduced number of nephrons with altered filtration surface and hypertension, hyperfiltration, kidney disease evolving into chronic kidney disease, the genotype may also be affected by modifiers and low birth weight and nutritional deficiencies and other aspects like obstructive or reflux nephropathy may affect at the end the final GFR. Nevertheless, there is a relationship between serum creatinine and GFR that has been clearly demonstrated, but especially for those conditions in which GFR is less than 60. For conditions higher than that, the level of relationship may not be so linear. So a serum creatinine of 1.2 may represent a GFR of 102 in an 18 years old or African American man, while it may be 46 in a 76 years old Caucasian woman. That's why people have tried to stay away from just serum creatinine and consider the plasma level of serum creatinine a combination of factors including creatinine generation, diet, excretion through gut and liver, and finally excretion through the kidney. And if you look at the different equations, at the end GFR should be simply the result of the generation divided by the plasma concentration. But this is a physiological process, usually not measured. And normally, GFR is considered like creatinine generation plus tubular secretion divided by serum creatinine at steady state, assuming that the amount that is generated and secreted equals to the amount that is excreted. This is what we measure in the formula, or better, we calculate in the different formulas, where age, sex, and race are surrogates for creatinine generation. And in fact, you see that when you go above 60 mLs per minute, both MDRD study, Cockroach Wolf, or even the CK-EPI formula are not so accurate as you can see in this slide. So the question is, and I would like to go mostly to the last two, there is a very low accuracy of eGFR in population without chronic kidney disease, in patients that have AKI. And what is the accuracy of eGFR when GFR is rapidly changing, like in the case of AKI? Practically none, because the assumption is that eGFR works at steady state. So these are the stages where we classify the chronic kidney disease, in fact, and the persistently loss of GFR is considered the possibility to diagnose a specific stage. But what about in AKI, where we use creatinine as a or even GFR as a tool to measure stage 1, 2, and 3, or risk, injury, and failure in the original rifle category? Well, certainly it works, because we have seen that this, moving from non-AKI to risk, injury, and failure, or stage 1, 2, and 3, describe definitely an increase in mortality, hospital and ICU length of stay, cost, and less renal recovery, right? But if we look at the kinetics of creatinine, creatinine starts to rise much later than the abrupt reduction in GFR that we observe after an insult. So the change in serum creatinine is a very late phenomenon after a change in GFR, and that's why eGFR is inadequate to test kidney function in AKI. And here you see at different level of baseline serum GFR, serum creatinine, how much does it take to cause an increase of 0.3 milligrams per deciliter in serum creatinine? Well, you can see that the delta GFR, if you have a creatinine of 1, may be greater than 30. But if you have a creatinine of 3, just 3 milliliters per minute delta may actually cause an increase of 0.3 milligram per deciliter. So why is GFR not currently measured in AKI? Why is it not measured in ICU? Because it is complicated. Because if you use an exogenous marker, it's complicated. If you use endogenous marker, it may not be perfectly reliable. And that's why people have tried also to measure urine output with automated systems. We also have tried this system, and we have tried to create specific trends to analyze this, but unfortunately, they were not sensitive enough. Recently, a paper has been published on what we call kinetic eGFR, but basically, this is just a retrospective calculation of what should have been the GFR in order to create such a change in creatinine, which is totally useless for our analysis. Plus, we know today that when you look at the GFR in sepsis, sometimes GFR may completely be reduced even in presence of a very steady or even increased blood flow. So having that said that, there are tools now that measure GFR immediately in real time, and that will be probably one of the future answers to this problem. By injecting specific fluorescent dextrans, for example, there is this method by Bruce Molitoris in Indiana, or this method used by MediBeacon, you simply have the possibility to measure on the skin of the patient the disappearance rate of this fluorescent method mean, and therefore calculate GFR. So this is how the system works. It is injected in the body, and then you start to increase the concentration. And when the concentration of this fluorescent mean reach the peak, at that point, you start measuring GFR. And you get a real-time measure of GFR. And this has been validated in different types of skins and so on. So I think this is a very important method for the future. Why? Because baseline GFR is not a stable function. And you can see here, in healthy, vegetarians, diabetic, pregnant women, you can get different level of baseline GFR. How can you say this guy, vegetarian, with a baseline GFR of 70 has a reduced kidney function? Well, the truth is that baseline GFR doesn't tell us anything. What we need to know is the maximal capacity under stress of the nephrons to provide GFR. And only when this part, which subtracted by this part represent renal functional reserve glomerular, can be identified, then you know exactly when you start having a reduced renal function, and then serum creatinine start to increase. So GFR increase after stress test, especially when you give high protein meal or amino acid infusion, and then you get probably a stimulus on the proximal tubular absorption, and then you have change in sensitivity to the macula densa, and a feedback provide an increase in glomerular filtration. This is something that we have already learned from the heart, where we have increase in activity or so-called stress test by physiological stressors like drug, pregnancy, exercise, or pathological stressors like hypertension, sepsis, diabetes, anemia, and so on. So GFR is not a synonymous of anatomical functional characteristic and is not a fixed function. It may be normal in spite of partial loss of renal parenchyma. Capacity of increasing GFR in response to protein load, glycine, dopamine, or other tools describe the presence of renal function reserve. And this has been used to evaluate filtration capacity in glomerulonephritis, renal transplant, kidney donor, solitary kidney, diabetes, and pregnancy. This is the kidney stress test as we provide by protein load. We basically measure GFR in baseline condition, then we provide the high protein meal, and then we measure GFR and we calculate the GFR after stress. The possibility of this increase and the capacity of the kidney to increase its level of function suggests the presence of a certain reserve. And this represents the difference between GFR measured after stress and baseline GFR in vivo. The capacity of the kidney to increase this level of operation depends on this level of renal functional reserve. And it is likely that renal functional reserve depends on the amount of nephrons available for recruitment and the ability to modify single nephron GFR. So under stress, you can see that basically you can have different response from different baseline levels. But for example, in subjects that have let's say a solitary kidney, renal functional reserve is marginal or absent because part of the nephron mass has been lost. What happened in pregnancy, for example? Comparing first, second, and third trimester, there is a progressive increase of baseline GFR due to utilization of renal functional reserve, and there is a reduction, of course, in the effective amount of renal functional reserve when you have complete utilization. In those patients who present gestosis or hypertension in the second and third trimester, we already identify absence of renal functional reserve at the beginning of the pregnancy. Now, this is the most recent result we have. Patients who have been tested for renal functional reserve before undergoing elective cardiac surgery and display a reduction in renal functional reserve have much higher level of AKI after surgery compared to controls with intact renal functional reserve. So there is an important issue that also regards recovery. And when there is an acute kidney injury, the reduction in GFR is compensated by recruitment of nephrons and utilization of renal functional reserve, so that creatinine does not increase until a certain point. And this remains subclinical. So even if creatinine remains normal, full repair and return to previous condition is not guaranteed. If renal functional reserve is lost, then acute kidney injury produces an increase in serum creatinine, and if repair is not complete, creatinine elevation remains permanent over time. And repeated kidney attacks may contribute to the progression of chronic kidney disease. So what happened is that you may or may not cross the line of altered normal baseline GFR, reducing renal functional reserve during a kidney attack, and you may or may not come back to normal level and full capacity of filtration. And in subsequent conditions, when you have another attack, you may actually cross this line, become clinical with an increase in serum creatinine, and return to normal, although the return at a level of baseline GFR, which seems to be normal, may not be fully and completely accomplished because renal functional reserve is lost. Now, there are some questions. Is renal functional reserve a valid prognostic factor for predicting long and term outcomes in ICU and AKI survivors? Returning to normal GFR does not mean restoration of renal mass, reversal, or histopathological changes. ICU survivors of non-dialysis requiring patients, renal function shows a progressive decline even if they had an initial recovery. An interrelation between returning to normal GFR and normal biomarker levels, clinical outcome, and renal functional reserve at short and long term is a question. So what could be the utility of stress test in clinical nephrology? Assessing baseline capacity of the kidney and assess a certain level of risk in different patients. This patient can be accurately prognosticated and can be planned for more aggressive intervention if required. And also, we use it, for example, to assess not only pregnant women, but also patients that are kidney donors. Is creatinine a good indicator for follow-up? Not at all. We have seen that the creatinine over time is not a good indicator. But what we have seen, look at this slide, and this paper is just submitted, is when you do 3 months follow-up after you did renal functional reserve, before doing cardiac surgery, those patients who have AKI display a loss in renal functional reserve when they had AKI stage 2 and 3, when they had AKI stage 1, and even when they had subclinical AKI. So, if you look at the process of renal recovery, you may have renal recovery when GFR exceeds 60 and finally ends up with more than 90. But this full recovery may be of 2 types. One, full recovery with intact renal functional reserve, or apparent full recovery when baseline GFR is still higher than 90, but renal functional reserve has been lost. At that point, this patient has a high risk, high susceptibility to develop AKI in the future. So I think that renal functional reserve should be taken into account to assess normal renal function and recovery after AKI. Baseline GFR, biomarkers, and renal functional reserve should be considered in every episode of kidney attack. Returning to normal biomarkers, urine output, or even baseline GFR seem not to be a reliable indicator of a good long-term renal prognosis. After ICU discharge, we should test renal functional reserve because it is a reliable predictor for renal long-term outcome, and better tests should be probably developed, especially for the critically ill, in order to be followed up at discharge. After these studies, what we have planned to do is a post-AKI clinic, and patients who develop AKI in the ICU are followed in the nephrology department in order to see what the renal functional reserve is, what the baseline GFR is, and what the long-term outcome is. Thank you very much.